The shoulder is a ball and socket joint that is surrounded by important muscles and tendons that keep this relatively unstable joint enlocated. The ball and socket has a mismatch with a relatively small socket and a very large ball, which is stabilized by the rotator cuff tendons, and deep to the tendons itself are structures that stabilize the joint. At the front of the socket itself in blue here is the labrum, which is a lining that surrounds the socket that deepens the socket and helps keep the shoulder stable. And in between the lining and the socket to the humerus and the arm bone is ligaments and capsules that are often damaged when your shoulder dislocates either at the front or the back. In surgery, to stabilize your shoulder is dependent on what structures you've damaged. If it's only soft tissue and it's the labrum and the ligaments at the front, this can be formed using keyhole methods to repair these structures at the front of the socket to make the shoulder stable once again. If you have lost bone due to your dislocations, which occurs commonly at the front of the socket, an open operation is performed where some bone is transplanted and inserted on the front of the socket to confer stability. This bone is taken from the front of the socket on a process called a coracoid, which is cut. Some important ligaments that are attached to this are then transferred and inserted on the front of the socket that then act to stabilize the shoulder. Shoulder instability manifests as a feeling that your shoulder is not stable. This may mean that you're not comfortable with your shoulder during range of movements, which are often those that are above the level of your shoulder with your arm extended, where your shoulder feels like it may pop out. Instability can also manifest as dislocations, with episodes where the ball and socket does genuinely dislocate and you may require an anaesthetic to put your shoulder back. A shoulder can dislocate both at the front and at the back, which is relatively more uncommon. Surgery is indicated for your shoulder dependent on your age, your level of function and your desires for sporting activities. It's also important that we trial physiotherapy in the first instance to strengthen your shoulder and then reassess whether the shoulder feels unstable or you have apprehension and worry that your shoulder may pop out. Patients that generally need operations are those that are younger, that are more high demand and have athletic pursuits that lead to their shoulder feeling unstable during these activities. The operation to stabilize your shoulder is dependent on the damage that occurred during these dislocation episodes. During your consultation, after examining you, we'll perform further investigations that assess both the bone and soft tissue structures. Using a CT scan, we can accurately assess whether you've lost any bone from either the socket or the ball that may be corrected during your operation, as well as commonly performing an MRI scan, which looks at the soft tissues that may be damaged. If it's an issue of soft tissue damage, this is often dealt with through arthroscopic and keyhole means, where the labrum and the structures that are torn at the front of the socket are reattached to afford stability of the ball and socket joint. If more extensive damage has occurred, where bone loss has occurred, particularly on the socket side, an operation is performed to restore the bone, where some bone is inserted on the front of the socket through an open operation. The risk of bleeding and infection is relatively low with a stabilisation procedure involving your shoulder. The risk of redislocation is dependent on the operation that is performed. The risk of redislocation with an open bony operation is less, where we restore the bone loss at the front of the socket. The risk with keyhole arthroscopic surgery is slightly higher.